when looking to the cause of death after HLA-matched transplant for acute myeloid leukemia, disease relapse remains the primary cause of death, whether in the setting of HLA-matched sibling or match unrelated donor. And despite significant improvement in recent years for young patients, prognosis of AML post-allo relapse remains dismal, with the majority of patients dying within 2 years. So why to prevent relapse? Well, because it's the first cause of transplant failure. For obvious reason, no one wants to see relapse. The treatment of relapse post-transplant is suboptimal for most diseases, and the treatment of relapse post-transplant is likely more expensive than prevention for most diseases. So the early attempts to prevent relapse using donor lymphocyte infusion to foster a graft versus leukemia effect were quite effective in chronic myeloid leukemia, less effective in acute myeloid leukemia and acute lymphoblastic leukemia. Therefore, what is more popular now is using post-transplant pharmacological intervention. Mostly, the most mature data are for hypomethylating agent and FLT3 inhibitors, with ongoing studies with venetoclax, IDH1, and IDH2 inhibitor. So the proof of concept for using azacitidine maintenance after intensive chemotherapy, this is outside the setting of allotransplant, was demonstrated in the HOVON study after intensive chemotherapy, as well as in the QUAZAR AML-001 trial that showed improved overall survival when using oral azacitidine. And actually, hypomethylating agents in the setting of allotransplant will favor graft versus leukemia effect by upregulating the expression of epigenetically silenced putative graft versus leukemia targets. So all fostering, these hypomethylating agents will not only be working on the leukemic clone, but will stimulate the adoptive immunotherapy. And the phase 1 study that was reported by Marcos de Lima in 2010 showed very good results with low dose azacitidine maintenance post-allo. So the dose is 32 milligram per meter square daily for 5 days and not the regular dose. And actually, the UK RICAZA trial later on reported improved outcome for patient receiving post-transplant azacitidine when this was associated with a CD8 positive T-cell response to tumor antigens. Similarly, in our institution, Dr. El-Sheikh in 2017 reported a 1-year DFS and overall survival of 63 and 70% for patients with AML and MDS who receive high-risk AML MDS who received prophylactic azacitidine. The French group by Thierry Guillaume also reported very good results using AZA-DLI post-transplant as post-transplant combined pharmacological intervention and donor lymphocyte infusion. We also have randomized trials, particularly 2 randomized trials with opposing results. The first is the MD Anderson trial, which is a phase 3 randomized trial of 5-AZA maintenance versus observation in high-risk AML MDS. And in this, the results were negative overall However, in this trial, patient received only a median of 4 cycles of azacitidine, which is very low and may explain the negative results of this study. And interestingly, in a subgroup analysis, patient who received 9 or more cycles of azacitidine or placebo had improved relapse-free survival with azacitidine compared to placebo. On the other hand, we have a much larger Chinese trial that involved more than 200 patients with high-risk AML in CR who were MRD negative after allotransplant, randomized to receive G-CSF in combination with low-dose decitabine or no intervention. And in this trial, there was a major improvement in leukemia-free survival and overall survival when using decitabine G-CSF. And again, immune cell subtype monitoring showed significant increase in CD8 and regulatory T cell and NK cell by the second or third cycle in the decitabine G-CSF arm. The other very popular post-transplant pharmacological intervention is using FLT3 inhibitors. As you know, FLT3 mutation are the most frequent in AML. We have internal tandem duplication of FLT3 in 25 to 30% and point mutation tyrosine kinase domain in 7%. And these FLT3 mutations are associated with increased risk of relapse at diagnosis as well as in the setting of allotransplant, and the results depend on the presence or absence of concomitant NPM1 mutations. So the worst results are for FLT3 ITD wild type NPM1. So we reported in early 2015 a pilot study on 6 patients with FLT3 ITD AML who received Sorafenib maintenance post-allo and were all in molecular complete remission MRD negative after relatively long follow-up. So these encouraging results led us to perform a multicentric to report a multicentric study from the American University of Beirut, Saint Antoine in Paris, and King Faisal in Saudi Arabia, involving 27 patients with a 2-year leukemia-free survival of 75%, overall survival of 83% when using Sorafenib, prophylactic Sorafenib post-allo for FLT3 ITD AML. Then we performed the EBMT registry study, and in this study, the use of Sorafenib was associated with a major increase of 2-year leukemia-free survival from 53.8 to 79.1%, and overall survival from 61.5 to 82.8%. And then we had, again, randomized trials. We have the SORMAIN German trial that showed major increase of relapse-free survival and overall survival when using Sorafenib maintenance. And actually, people always criticize registry studies, but here I wanted to point out that the results reported in the SORMAIN trial were almost identical to those that we previously reported in the EBMT registry study, showing overall survival benefit from Sorafenib. And similarly, we had the Chinese randomized trial that showed improved overall survival and leukemia-free survival with the use of Sorafenib due to decreased risk of relapse. And importantly, in this large randomized phase 3 study, Sorafenib benefit was observed in all subgroups, regardless of pre-transplant use of sorafenib and regardless of the MRD status. And in terms of mechanism of action, we have an elegant work published by the German group in Nature Medicine in 2018, showing that sorafenib promotes graft versus leukemia activity in mice and humans through IL-15 production in FLT3-ITD mutant AML. So what about other FLT3 inhibitors? We have some numerical increase in outcome with midostaurin in the RADIUS trial, but these did not reach statistical significance. We have also in the for Quizartinib in the Quantum First study overall survival numerical benefit in patients who received allotransplant in CR1, particularly if they were MRD positive, but these numerical benefits were not statistically significant again. And finally, we have the recent report from the Morpho trial that randomized Gilteritinib versus placebo as post-transplant maintenance in AML with FLT3-ITD. So this trial did not meet primary endpoint. There was no improvement with Gilteritinib in relapse-free survival, no improvement in overall survival. So Gilteritinib decreased the relapse incidence, but increased non-relapse mortality, and overall there was no difference in survival. In this trial, patients who were MRD negative had, of course, a better outcome than MRD positive patients. And in the planned subgroup analysis, Gilteritinib improved relapse-free survival in the setting of MRD positive, but not in MRD negative patient. And again, no improvement in overall survival, neither in the MRD positive nor in the MRD negative. And interestingly, the results were quite different by geographic location. So Gilteritinib was associated with improved relapse-free survival in North America, decreased relapse-free survival, so lower results with Gilteritinib compared to placebo in Europe, and similar results of Gilteritinib and placebo in Asia Pacific. So in terms of guidelines, we published in 2020 the clinical practice recommendation, a position statement for the acute leukemia working party of the EBMT for AML patient with FLT3-ITD. And in this position statement, post-transplant maintenance therapy with a FLT3 inhibitor for patient who underwent allotransplant for FLT3-ITD AML is recommended except for patient with active acute GVHD, and in the absence of an appropriate clinical trial, sorafenib could be considered as the preferred option. And in the NCCN guidelines in the version 6/2023, a FLT3 inhibitor maintenance is recommended for patients in remission with a history of FLT3 mutation. So the sorafenib is the preferred option, category 1, and the other options, midostaurin, Gilteritinib, and Quizartinib as category 2B. And finally, I would like to report very briefly the EBMT survey on practice pattern of transplant centers regarding maintenance treatment post-allo in AML. 115 EBMT centers responded. 89% of centers implement maintenance strategy post-allo. 64% use hypomethylating agents, primarily azacitidine. 83% use FLT3 inhibitors, by a large majority sorafenib. Thank you for your attention.